Okay, so welcome back to this next video in which we are discussing depression and the antidepressant drugs. Okay, right. So we've now discussed the monoamine hypothesis. Now what we're going to go on to is looking at the antidepressant drugs. Now, as I said in the previous video, all of the antidepressant drugs, from what we understand of how they work, they raise noradrenaline or serotonin levels, or both of those two monoamine transmitters. Okay, some of them even raise all three monoamines. They raise dopamine as well. Okay, now the monoamine hypothesis was just that though depression was caused by the monoamines being too low, and therefore the simple explanation of the antidepressants working was that it raised the monoamines and therefore you'd cured the depression. Okay, the monoamine hypothesis is losing favour basically, in favour of depression being a problem on the level of the anterior cingulate cortex, specifically overactivity in the anterior cingulate cortex. Okay, and one of the main arguments against the monoamine hypothesis, which I know I've reiterated many times now, but it is so important, so I'll say it again, is that antidepressants, you take one pill and they will raise your serotonin and your noradrenaline and maybe even your dopamine levels. Okay? However, they do not cure your depression after one pill. You have to take them for weeks before you get any sort of antidepressant effect. So the the sort of main dogma on which people work now is that no, depression is not caused by too low levels of monoamines. Instead, it's caused most likely by overactivity in the anterior cingulate cortex. The antidepressants then raise noradrenaline and serotonin levels, okay, and then that causes remodeling of the anterior cingulate cortex, and that changes the depressive state. Okay, that cures the depression. Okay, so the idea is that by long administration of the antidepressants, that you gradually change the structure of the brain so that the depression goes away. Okay, right. So let's now talk then about the different categories of antidepressant drugs then. So we will start off with the most widely prescribed antidepressant drugs now, which are the SSRIs. Okay, so what does SSRI stand for? So SSRI stands for the selective, that's the first S, then the second S is for serotonin, okay, the R is for reuptake, okay, and the I is for inhibitors. Okay, so these are drugs which stop the reuptake of serotonin. They inhibit only the reuptake of serotonin, basically. Okay, their name tells you exactly what they do. Now, how do they do this? Well, you remember me telling you about the serotonin reuptake transporter, the SERT, okay? That transported the serotonin from the extracellular fluid back into the cytoplasm of the axon terminal. Okay, these drugs bind to the serotonin reuptake transporter where serotonin would bind and block serotonin from being able to bind there. Okay, and hence they block the activity of the serotonin reuptake transporter, and hence serotonin is not reuptaken back into the axon terminal and remains in the extracellular fluid. So that therefore raises the levels of serotonin. Okay, so examples of drugs in this category. The first and most famous example by far is fluoxetine. Okay, now you might be thinking, what? That's not famous. Well, let me give you its brand name. So fluoxetine is its generic name, okay, its real name. The brand name, the first brand name was Prozac. Okay, and that's still a very, very famous and recognized brand name in common culture. Okay, right. Other selective serotonin reuptake inhibitors which are not as famous as fluoxetine are paroxetine. Okay, so generally the selective serotonin reuptake inhibitors do end with the exetine suffix. Okay, and now I'm going to give you two exceptions to that. Another one is sertraline. Okay, and then a very commonly prescribed drug also is citalopram. Okay, so those are 4 examples of selective serotonin reuptake inhibitors. There are more, okay? The list goes on and on, you know. Every drugs company has a selective serotonin reuptake inhibitor that it makes. Okay, so there are lots of these drugs. Okay, and they are selective for blocking the serotonin reuptake transporter, not okay, so they will not block the norepinephrine transporter or the dopamine transporter. Okay, so now we're going to discuss another class of drugs, which are the SNRIs. Okay, and this stands for the serotonin, that's the first S, and then, whoops, serotonin, okay, and then it's / norepinephrine, okay, that's the N, and then it's reuptake inhibitors. Okay, so these drugs are going to block the reuptake of not only serotonin, but also norepinephrine. Okay, so they bind to the serotonin reuptake transporter, but also they bind to the norepinephrine transporter, and both of them this time they block the activity of. Okay, this means that serotonergic and noradrenergic neurons are not going to be reuptaking serotonin and noradrenaline. Okay, so the levels of serotonin and noradrenaline in the extracellular fluid are going to go up. Okay, so the main example of a serotonin norepinephrine reuptake inhibitor is venlafaxine. Okay, but as we'll see, many of the tricyclic antidepressants could be counted as serotonin norepinephrine reuptake inhibitors. Okay, so this is another class of antidepressants. Okay, right, let's now get another piece of paper and continue on. Okay, so the next class of antidepressants I want to discuss is the tricyclic antidepressants, and these really just do exactly the same as the SNRIs. Okay, the difference is that the tricyclic antidepressants are older. Okay, so these are older drugs than the SNRIs. Okay, and they are also characterized by having a certain chemical structure. Okay, they have a tricyclic structure within them. Okay, so the SNRIs are newer and they don't have the same chemical structure as the tricyclic antidepressants, despite the fact that the tricyclic antidepressants do the same thing as the SNRIs, which is that they block both the SERT and the NET. Okay, right, so let me give you examples of the tricyclic antidepressants. So imipramine is a nice example of a tricyclic antidepressant. Okay, another example is desipramine. Okay, and then my final example is amitriptyline. Okay, so they all sort of end in an "ine", amitriptyline. Okay, how am I spelling this? Amitriptyline, like that, I think is how you spell amitriptyline. Okay, those are my 3 examples of tricyclic antidepressants. Now, just for your knowledge, tricyclic antidepressants are often abbreviated as TCAs. TC for tricyclic, and then A for antidepressants. Okay, right. So again, these 3 drugs will bind to and inhibit the serotonin reuptake transporter and also the norepinephrine transporter, and therefore block the reuptake of serotonin and noradrenaline into the axon terminals of serotonergic and noradrenergic neurons, and therefore the serotonin and the noradrenaline will remain in the extracellular fluid, and the level of it in the extracellular fluid will hence increase. Okay, right. So again, they're raising both serotonin levels and noradrenaline levels. Okay, and now the next category, thankfully, does something different. Okay, so these ones are a little bit more interesting. So they're the monoamine oxidase inhibitors, and we've already seen an example of a monoamine oxidase inhibitor. We saw the example of iproniazid, the anti-tuberculosis drug. Okay, but there are other monoamine oxidase inhibitors as well. Okay. Now, for short, monoamine oxidase inhibitors are abbreviated to MA for monoamine, and then O for oxidase, and then I for inhibitors, so MAOIs. Okay, right, so there are 3 monoamine oxidase inhibitors that I'm going to give you. The first we've seen already, that was iproniazid, the anti-tuberculosis drug. That is no longer used, okay, but it was the first antidepressant ever to be discovered, okay, so it's notable despite that. Then another monoamine oxidase inhibitor is phenelzine, okay, and then finally another monoamine oxidase inhibitor is tranylcypramine. Okay, now all three of these monoamine oxidase inhibitors are non-selective for monoamine oxidase A over monoamine oxidase B. Okay, so they will inhibit both monoamine oxidase A and monoamine oxidase B. Okay, right, so they will well, let's talk about how this works then. So they inhibit these monoamine oxidase enzymes. What does that mean now? That means that these enzymes will no longer be breaking down serotonin, they'll no longer be breaking down dopamine, and they'll no longer be breaking down noradrenaline. Okay, so the amount of serotonin and dopamine and noradrenaline that is going into synaptic vesicles will increase, and therefore the vesicles will become full of serotonin, noradrenaline and dopamine in the serotonergic, noradrenergic and dopaminergic neurons respectively. So all of the monoamine systems, all three of them, are now going to be releasing more neurotransmitter. So the monoamine oxidase inhibitors not only increase noradrenaline and serotonin like all the others that we've seen, but they also increase dopamine. Okay, and they are effective at treating depression. Okay, there is a problem with the monoamine oxidase inhibitors, which is known as the cheese effect, okay, so I'd like to discuss this now. So the problem is that monoamine oxidase A is not just found in neurons, okay, it's also found in liver cells, hepatocytes, and also cells of the intestine, okay, so enterocytes. Okay, now what do the cells of the intestine and the liver do with the monoamine oxidase A? Well, they break down dietary monoamines, so monoamines coming in the diet. Now, a really important monoamine that's coming in the diet is something known as tyramine. So let me show you the structure of tyramine. So basically, tyramine is tyrosine, the amino acid tyrosine, without the carboxylic acid group. Okay, so it's got a very similar structure to dopamine. So let me draw this here. So here is the amino group, here's the alpha carbon. We've now got rid of the carboxylic acid group. Okay, we've got the methylene group here. Okay, and then we've got the benzene ring here. And I don't know why I've suddenly inconsistently changed from showing a benzene ring as alternating double and single bonds to with the ring instead. Okay, but never mind, it's a benzene ring. Okay, like so. So this is tyrosine with no carboxylic acid group here, so it's no longer tyrosine. Okay, instead it's called tyramine. You will notice that it's very similar structure to dopamine. In fact, if we added an alcohol group on here to turn this into a catechol ring, then it would be dopamine. Okay, now, this is found in the diet, okay? It's found in the diet in cheese, okay? And other things as well, but cheese is the famous example that you find tyramine in, okay? Now, normally, when you eat cheese, what will be happening is you'll get a lot of this in your diet, and it will be going into the enterocytes, and it will be being broken down by monoamine oxidase A in the enterocytes, okay? And that tyramine that gets past the enterocytes into the blood will go on to the liver, okay? Because remember, all of the blood that's coming from the intestines, I'll draw some picture here, okay? So if we've got a little bit of the intestine here, okay, remember all of the blood that's coming from the intestine goes firstly to the liver, okay, before it goes back into the systemic circulation. Okay, so here is the other portal vein, the hepatic portal vein. Okay, so it goes to the liver, and then the tyramine in the blood will be removed by the hepatocytes and will be broken down by the monoamine oxidase in the hepatocytes. Okay, so this is the hepatic portal vein here. Okay, right. So usually you don't get much tyramine actually going into your systemic circulation. If, however, you are taking monoamine oxidase inhibitors for your depression, then if you eat cheese, the tyramine will go into your blood. Now, why is this such a bad thing? Well, basically, it's going to cause something known as the cheese effect, okay, which basically involves blood pressure going through the roof, okay? Now, why does it cause blood pressure to go through the roof? So you remember that I told you that your blood vessels, particularly your arterial blood vessels, so for instance your arteries, your arterioles most importantly, they have a layer of smooth muscle surrounding them, okay? So a layer of smooth muscle cells surrounding them. And these smooth muscle cells are innervated by noradrenergic neurons, okay? Specifically noradrenergic neurons of the sympathetic nervous system. Okay, so this is a noradrenergic neuron. Okay, here. Now, basically what can happen is tyramine can be mistaken for noradrenaline at these axon terminals. Okay, so what happens is if this is the axon terminal, the noradrenergic neuron, okay, the norepinephrine transporter, the NET, mistakes tyramine for noradrenaline and ends up pumping the tyramine into the cytoplasm of the axon terminal. Okay, so in comes the tyramine. Okay, now in the axon terminal, what then happens is the tyramine ends up being loaded into the synaptic vesicles. Okay, so it goes into the synaptic vesicles by the vesicular monoamine transporter. Okay, so I'll put it in here. So here is VMAT2, and basically what ends up happening is it displaces the noradrenaline that is in the synaptic vesicles. Okay, so what ends up happening is all the noradrenaline starts leaving the synaptic vesicles as the synaptic vesicles get filled up with tyramine. Okay, then what you end up with is a very high concentration of noradrenaline in the cytoplasm of the axon terminal. Now, remember the norepinephrine transporter, it worked through secondary active transport. It transported noradrenaline from the extracellular fluid into the cytoplasm, along with sodium down its concentration gradient. Okay, so it relied on the gradient of sodium being stronger than the gradient of noradrenaline, okay, because otherwise the amount of energy released by the sodium going down its electrochemical gradient wouldn't compensate for the noradrenaline being moved up its concentration gradient. If we now put an absolutely massive concentration of noradrenaline in the cytoplasm of the axon terminal, then the gradient of noradrenaline into the cell will become just too big, basically. And what actually ends up happening is the norepinephrine transporter works in reverse and starts pumping the noradrenaline out of the cell now. Okay, and then you get a massive release of noradrenaline onto the smooth muscle cells. Okay, the smooth muscle cells then contract, and that causes blood pressure to go through the roof, because now the blood is in a smaller volume. Okay, so blood pressure will therefore go up. Okay, so that's what underlies the cheese effect. Basically, tyramine is capable of causing all of the peripheral noradrenergic neurons which innervate the blood vessels to start releasing noradrenaline, and that causes them all to contract. Okay, right, so that's something to be aware of if you're taking monoamine oxidase inhibitors, that you need to avoid tyramine-rich foods such as cheese. Okay, right, so we're now going to go off the antidepressant drugs, and we're going to turn our attention onto other forms of treatment for depression. Okay, particularly we're going to talk about psychotherapy firstly, and then we're going to talk about electroconvulsive therapy. Okay, so psychotherapy firstly. So, the particular form of psychotherapy that is used in the treatment of depression is cognitive behavioural therapy, CBT. Okay, now what does cognitive behavioural therapy consist of? Well, basically, what happens is the person with depression will sit down with a therapist, okay, and the therapist will talk through their views with them. Okay, so remember, in depression you are having a huge number of negative thoughts. You can't experience happiness. You have negative thoughts about everything. Okay, and what the therapist will do is they will sit down and they will talk through these thoughts, and they will try firstly to identify the negative thoughts with the person, and then they'll try and talk through these thoughts with them, and they'll ask them to explain why they have such negative thoughts. Why are they feeling so negative towards this? And what they'll try and do is show them how actually, things aren't actually that bad. They'll try and change their thoughts to being happy with regards to things. So cognitive behavioural therapy is all about trying to change the thoughts so that they become happier, basically. Okay, and it does work. Okay, what would be interesting to know is how doing cognitive behavioural therapy affects the structure of the anterior cingulate cortex. So if we think depression is because of overactivity in the anterior cingulate cortex, it would be nice to see that cognitive behavioural therapy decrease that overactivity in the anterior cingulate cortex. And as far as I know, studies like that haven't yet been done. Okay, right. So the next treatment we want to talk about is ECT. Okay, now this sounds terrifying, okay, and it is quite terrifying, okay. However, it is the closest thing that we have to a cure for depression. It does work incredibly well, okay. It often does cure depression, okay. It comes with its drawbacks, obviously, okay, and it is only used in severe intractable depression that is probably going to lead to suicide if left untreated. Okay, so what does it involve? Well, basically it involves giving the patient a general anesthetic. Okay, so they're unconscious now, and then what you do is you electrically stimulate the brain. Now don't worry, you don't have to cut open their skull. You can do this without cutting open their skull. Okay, so you electrically stimulate the brain, okay, and you induce basically a generalized seizure. Okay, so all the neurons start firing all in synchrony, and that's a generalized seizure basically. Okay, and then when they wake up, the depression's gone basically, like magic. That's electroconvulsive therapy. Okay, now what's the side effect? Well, the main side effect and the main curiosity, actually, this is a big thing that people use who are interested in the neural correlates of memory. Okay, so the main side effect, which is very interesting if you're studying memory, is that they get retrograde amnesia. Okay, so they lose memories. Okay, they can't remember what's happened in the past, but it's not that they lose all their past memories. They only lose the recent past memories. So within a few weeks or so, basically, of having the electroconvulsive therapy. So they don't remember their, they don't lose their childhood memories. Okay, they just don't remember actually coming to the hospital and having the electroconvulsive therapy. Okay, so they get retrograde amnesia, but it's only recent retrograde amnesia. So retrograde just means in the past, and amnesia means that you've lost memory. Okay, so they get recent retrograde amnesia, and that's curious. Okay, that shows us that there is something about recent memories that is not stored in the permanent structure of the brain, basically. It shows us that that is stored potentially in the electrical activity of the brain rather than the actual structure of the brain. Okay, so that's an interesting curiosity if you're interested in memory. Okay, right. So once again, I'll stress that although this sounds terrifying, it is the closest thing we have to a cure in depression. It is to depression. It is extremely effective. Okay, right, but it is, because of the side effects, it is only used for extremely severe cases of depression. Okay, right. The final thing then that I want to talk about now is a treatment for mania. Okay, so remember, we have focused completely on the depressive periods of major depressive disorder and also bipolar disorder. I have not told you at all about how to treat the manic periods of bipolar depression. Okay, and in fact there is a drug that is used to treat bipolar depression, which firstly treats the manic periods, but also actually treats the depressive periods as well. Okay, so people with bipolar depression tend not to be given the normal antidepressants. Instead, they are treated, I keep saying tret, and it's not a real word, treated with the drug Lithium. Okay, so basically Lithium is just an atom. Okay, it's not even a molecule, it's a single atom. Okay, lithium is in the same group of the periodic table as sodium. Okay, it's actually smaller than sodium. So remember, in group 1 of the periodic table, the alkali metals, okay, the first thing you have is lithium. Okay, then underneath that you have sodium. Okay, and I shouldn't have put a positive charge there. And then you have potassium underneath that, and I can't remember what goes after that. I think it's rubidium or something along those lines. Okay, so these are the alkali metals. So lithium is used to treat bipolar depression. Okay, right. Now, you won't be surprised to know that the mechanism of action of lithium is not understood. However, it is incredibly effective at stopping the manic periods. Okay, so it has been labelled as a mood stabilizer. It's capable of stopping these manic periods. It's also capable of stopping, to an extent, the depressive periods as well. So it lowers down the manic periods, it lowers down the depressive periods, it stabilizes your mood around normal, basically. Okay, and the word that means that your mood is at the normal level is euthymia. Okay, so euthymia means that you have a normal mood, basically. So it stabilizes you to a euthymic mood, we might say. Right, so we don't know how it works. However, we do know something about how it works. How this mechanism that I'm about to tell you about has anything to do with stabilizing mood, we don't know that. But we do know something about what lithium does, which is that it inhibits the regeneration of phosphatidylinositol 4,5-bisphosphate. Okay, right. Now, if you don't have a clue what that means, don't worry, I'm about to go through this in more detail. So, basically, in order to understand phosphatidylinositol 4,5-bisphosphate, we need to understand something about G protein coupled receptors. Okay, so basically, on the surface of cells, one of the key types of receptors is G protein coupled receptors. Okay, often abbreviated as GPCRs. So this stands for G protein coupled receptors. Okay, so there are over 800 different types of G protein coupled receptor in humans alone. Okay, so this is a major family of G protein coupled receptors, and a huge number of receptors work through G protein coupled receptors. For instance, most of the receptors for the monoamines, so serotonin, noradrenaline, and dopamine, they are G protein coupled receptors. For serotonin, you know, there are 13 different G protein coupled receptors which respond to serotonin. Noradrenaline, there are 9 different receptors for that. Dopamine, there are 5 different G protein coupled receptors for dopamine. So these are very, very important G protein coupled receptors. Okay, so let me show you the structure of a G protein coupled receptor. So if this is the cell membrane here, okay, G protein coupled receptors all have a conserved structure. Okay, firstly they're all individual proteins, so they have their amino terminus extracellularly, okay, like so. Then the polypeptide, represented by this line here, will straddle the membrane once, okay, then it will straddle the membrane a second time, a third time, okay, a fourth time, a fifth time, a sixth time, and then a seventh time, and then you'll have the carboxylic acid terminus intracellularly. Okay, so this is the basic structure that all G protein coupled receptors share. They have the 7 membrane-spanning alpha helices. So let me highlight these up. So, highlighted up in green here, these are our 7 membrane-spanning alpha helices. okay, and these are labelled TM1 to TM7. Okay, so the first one here that's closest to the amino terminus, this will be called TM1, standing for transmembrane domain 1. Okay, so the T is for trans, and then the M is for membrane. Okay, so this is TM1, transmembrane domain 1. Then we've got TM2, transmembrane domain 2, TM3, transmembrane domain 3, TM4, transmembrane domain 4, TM5, transmembrane domain 5, and then TM6 and TM7 as well. Okay, so those are the core structures of a G protein coupled receptor, that they have to have the 7 membrane spanning alpha helices. There are some other core structures of G protein coupled receptors. For instance, here we have the intracellular loops in orange here. Okay, so these 3 loops that are between TM1 and TM2, between TM3 and TM4, between TM5 and TM6, these are known as the intracellular loops. Okay, and for short, the intracellular loops are often abbreviated to the ICLs. Okay, so the first intracellular loop is the one between TM1 and TM2. Okay, and this is known as ICL1. The second intracellular loop is between TM3 and TM4, and this is known as ICL2. The third intracellular loop is between TM5 and TM6, and this is known as ICL3. Okay, right, so those are the 3 intracellular loops, and then we also have extracellular loops coloured in here in red. Okay, so these are labelled up ECL1, extracellular loop 1 between TM2 and TM3, ECL2 between TM4 and TM5, and then ECL3 in between TM6 and TM7. Okay, finally, the only 2 portions that I now haven't coloured in, but which are also core structures of G protein coupled receptors. Firstly, we have this portion here prior to TM1. Okay, and this is known as the amino terminal domain, or the ATD for short. Okay, so this stands for the amino, and then it's terminal domain. Okay, right. So that's often shortened to ATD. Okay, and then we also have that portion after TM7, which is down here. Okay, and that then is called the C-terminal domain. Okay, and for short, the C-terminal domain is abbreviated to the CTD. Okay, so this stands for C-terminal domain. Okay, so that's the basic structure of a G protein coupled receptor then. Okay, now, G protein coupled receptors, they are so called because they are going to activate heterotrimeric G proteins. Okay, now the heterotrimeric G protein we are going to be specifically interested in is what's known as the GQ heterotrimeric G protein. Okay, and what this means is that one of the subunits is going to be a particular type. Okay, but we'll see that in the next video.